Hi all, good evening. Yeah, welcome to another session of Toxic and Series. We have Dr. Jerin with us discussing about bites and stings. It's the most discussed topic right now. Dr. Jerin completed her MT from Tamara Institute of Medical Science and now working as a consultant emergency physician at Masdeva Med City, Kerala. Thank you for delivering this speech, Dr. Jerin, and over to you. You can start the session.
So hi, good evening, everyone. So as Dr. Vaishak has said, I'm Dr. Jerin Miriam Johnson. I'm a consultant from Masliva Medicity, Pala, there's a place in Kottayam. So today we are actually going for a session, which is actually we come across in our ER very often, and it's something that we actually find it very difficult also to manage, or maybe to what convey to the bystanders how serious is it, or how less serious or less fatal it is. And we itself be in a dilemma whether to is it actual issue, or is it just a dischargeable patient. So this session is actually more for your exam oriented kind of session. So this is particularly for your so that you can have a constructive idea on how to write if such a question is being asked. And you can actually also, it is also a more into a practical oriented session also. And a detailed of this session will be done in our later live sections, because the unknown bite is actually a vast topic. There's so many things that come into it, so everything needs separate emphasis. But here what I'm doing is a constructive way of how you can approach to a patient when they come with an unknown bite in your ER. Yeah, I think I'm audible to everyone. Yeah. So now let's go to our first slide. So this is actually a scenario or a situation that we faced in Kerala recently. That was in April. As you can see, it's a newspaper cutting from the Hindu in April. It's in April 19th and April 23rd that you can see. So I'm just starting off the session by this particular cut of the newspaper, right? Because in the first one, both are, as you can see, both are 8-year-old boys. Okay, they are both are boys. Yeah. So the first cutting, it was actually the story behind that situation was there were two kids, two kids who were brothers. They had attended a temple function the night before sleeping. So while they were sleeping, suddenly one of the boy wakes up with abdominal pain, and he starts vomiting. And the parents were like, okay, they just had food from outside, so it might be possibly food poisoning or something. So it was like that. They just went through that. But the second child, the younger one, also started having abdominal pain and started having vomiting. They were like, okay, this is also food poisoning. But what happened is, next, after 1 or 2 hours, both the kids were very sick. They became very sick, and they were taken to a nearby hospital. From there, they actually noticed there were bite marks on the leg. And one of the child actually expired very soon. But due to our management, the other boy, the elder one, was saved. And that happened in April 19th. Next one happened in April 23rd. Similar scenario. But the only thing that the parents could notice, or they noticed the bite mark first itself. So what happened was, emergency or the correct management was done for that child. So he was also saved. But what happened, out of the three, one of the boy we couldn't save, because the parents couldn't notice, they didn't notice the bite mark, and right management could not be given at the right time. And the alarming clinical features could not be found, or maybe could not be identified at the initial presentation. They couldn't identify it was such an alarming symptom. So this is where this session comes, the importance of this session comes through. So first, let's go the ED dilemma. As ER consultants and as PG residents, we actually come across this ED dilemma of how to approach or when to actually, be cautious for an unknown bite. So the trap is that most of the snake bites, or 30% of the snake bites, or 30% of the unknown bites, they initially don't present with the emergent symptoms at the on arrival. So they actually present in the later few hours. So we actually might find it very difficult whether to actually discharge the patient or should we admit the patient, or if we tell the bystanders, right, it's an unknown bite, there'll be many complications, but they won't be accepting. So that is one trap we have when we come across such a case. And what the rule in emergency is that it is mostly what we have to have is a syndromic approach to an unknown bite. Okay, a syndromic approach is better than a zoological classification or a zoological identification. So we should have that syndromic approach when we have a case of unknown bite. So first, the objective of this session is that first you have to deconstruct all your biases of we'll treat once we know what actually bit the patient. Okay, that perspective should be actually deconstructed. Second is we have to master the 4 primary toxidromes that we come across when you get a patient with unknown bite. And third, how to have a standardized investigations or standardized approach. That is, what are the high yield bedside diagnostics that you can do? That is the 20-minute whole blood clotting test, a single blood count test, a POCUS, as we can see. And then we have to optimize, that is when to give anti-snake venom, or when to give tetanus, rabies, or when to give any other immunoprophylaxis. And then we have to identify the immediate causes or immediate admission. When should we admit the patient immediately? That is a strict 24-hour observation protocol that we have to follow. So why unknown bites are high risk? One is the first thing what we come across is misidentification. So most of our patients will be like, okay, something bit them. They were like, okay, it might be a snake. Oh, no, it might be something else. They didn't see it was a mammal. Okay, so it's a misidentification is one of the major issues that we come through when we deal with unknown bites. Next is the dry bite trap. That is about 50% of the venomous snakes. Okay, they do not inject venom. So we actually create a false sense of security. That is, we actually tend to admit those patients, or we tend to not admit those patients. Then another issue is that we get delayed neurotoxicity signs. That is, in species like common kraits and all, they actually develop symptoms only after a few hours of the bite. And the next is never rule out any envenomation based on your patient's story. So this is what you have to, these are the high-risk issues that we come across in ER. Okay. So next is the golden minute stabilization. So what is the golden minute? That is initial 10 seconds or 1 minute. What you can do is, first is you have to identify the immediate anaphylaxis check. Okay, that is, you have to look for, as you can see, ABC. Okay, that is your airway. Airway should be patent. That is, there's no signs of any angioedema, stridor, wheezing, or any refractory hypotension. In those cases, if there's any anaphylaxis-like features, definitely you have to go for our routine protocol, that is adrenaline. Yeah, and do not wait for any of your cutaneous rashes. Okay. Yeah. Next is you have to look for your neurorespiratory evaluation. That is, you should never rely on your pulse oximeter. Always look for your single breath count. Okay. That is, you ask the patient to count as long as possible in a single breath. Okay. And next is you should look for bulbar reflexes and also a neck flexion strength. The issue with, okay, I'll come to that in the later slides. And next is fluid strategy. You should always secure 2 large bore IVs and always try to avoid aggressive crystalloids. Okay, that is, one is it can exacerbate your local tissue edema, and it can worsen your compartment syndrome, or also in some cases when you have there will be in your syndromic approach, patients can come in palm edema. In those cases also, this fluid strategy should be maintained, or it should be done in a controlled flow. Yeah. And so now how do you approach? That is, first, as I've said, stabilize the patient. First, mobilize the limb and remove all the bands and bangles, whatever they have, remove everything, because patients will have local reaction. That is, it can cause local edema. Next is we have to divide into 2, asymptomatic and symptomatic. So in case of symptomatic, we identify the syndromes. The syndromes I'll be dealing in the next few slides. And according to that, we initiate targeted protocols. In asymptomatic patients, we actually go for the observation protocol. So what is a syndromic approach that we have? First is we have neurotoxic protocol. So neurotoxic protocol are your elapid bites. That is, you viper. It includes your, not viper, cobras and kraits. Okay. In these cases, what is the pathophysiology is that you get presynaptic or postsynaptic neuromuscular blockade. So they'll be disrupting your acetylcholine transmission. So what they will present as? One is ptosis. Ptosis is the earliest sign of neurotoxic protocol. Next is diplopia, blurred vision, dysarthria, and dysphagia. That is your bulbar signs. The next later signs or the respiratory signs include descending flaccid paralysis, broken neck sign. That is, their inability to lift their head. Then there's paradoxical respiration, diaphragmatic paralysis. So these are the neurotoxic syndrome spectrum. Okay, this is the early signs or the late signs that you have looked for first. That is the neurotoxic protocol. Now, how do you go forward with it? That is, if there is any airway patents, if there's any issues with the airway, we actually have to secure it. Then the single breath count test. What happens in single breath count? When you come into the practical issue, in this scenario, most of your patients are anxious, right? So when we get anxious, we'll have shortness of breath. So in this case, in this scenario, what you have to do is you ask the patient to take a single breath, okay, and ask the patient to count the maximum they can do. So in most cases, they're anxious, they won't be able to count, until 30. So what you can do is a serial assessment should be done. That is, if initially the patient was able to count until 24, and when you reassess, the patient is not able to count till 24 or something, that means the patient is having a shortness of breath. In that case, you have to rapidly go for your rapid sequence intubation. That is, you go for a prophylactic ventilation. And neurotoxic, it's usually cobras and kraits, they cause neurotoxic syndrome. So in that case, you can go for polyvalent ASV infusion, and also keep epinephrine on your bedside to manage your anaphylaxis. Next is for a neuromuscular rescue. So you can actually go for your atropine neostigmine challenge. Okay, and it should be done only after initiating your ASV. So this snake bite, as such, the session will be conducted in our later live sessions. Okay, so this is actually, I'm going for a syndromic approach. Okay, so this is a short things that you can actually write in your exams. And any patients fitting into this criteria should be admitted. Okay, and they'll actually show progressive descending paralysis also. So they need to be admitted in the ICU. And when do you discharge? Patients extubated and they have stable respiratory baseline, full resolution of your ptosis, dysphagia, they're tolerating oral intake for 24 hours. So that is the discharge criteria for a neurotoxic syndrome. Yeah. And next is your hematoxic protocol. That includes your viper, pit viper. So what happens when you get a bite? from a pit viper. It usually causes venom-induced consumption coagulopathy. So your procoagulant enzymes like your prothrombin activators, factor 10, factor 5 activators, right? Those actually consume all your clotting factors and they can actually cause systemic hemorrhages. So what is the local signs that you get is there'll be continuous bleeding or oozing from the bite puncture site. And what are the systemic signs that you can notice is gingival bleeding, epistaxis. You can have hematemesis, hematuria, hemoptysis, spontaneous intracranial hemorrhage. So the issue is that in these pit viper, there is another issue is that some patients might develop the symptoms on a later basis. Yeah, so we have to be very cautious in those patients. So in this, what we can do is we can go for a coagulation screening. That is, draw blood for a 20-minute whole blood clotting test. And it should be repeated every 30 minutes until your results are normal. Okay, and you should always have a clinical, should have a high clinical suspicion. Yeah, and it's the standard diagnostic is 20-minute whole blood clotting time, but the only drawback is whole blood, you can't actually fully rely on whole blood, because if there are impurities, if you're doing your whole blood clotting time in a plastic bottle, it is definitely going to give a false result. If you're doing a glass tube and it has impurities in it, that itself can actually vary your clotting test. And if your temperature in your ER, okay, that actually also affect your clotting time. So in those cases where you are having not very there's not much local signs, or there is not much any systemic signs, but the whole blood clotting test is having a positive result, you should always cross check with your coagulation profile, that is your PT, APTT, INR. If that is also deranged, then you can actually go for your ASV. So in hematoxic, if there are hematoxic syndrome symptoms, then you actually go for polyvalent ASV. Okay, that is, the ASV should be administered immediately. And you should always avoid unnecessary IM injections, because there is consumption coagulopathy. And the resuscitation rule is administer the ASV, okay, and your blood components should be administered only after completing your ASV. That is, it's just to avoid your consumption coagulopathy. And what is the discharge criteria? 2 consecutive normal 20 whole blood clotting time. Okay, that is 6 hours apart. And there is complete cessation of active bleeding. And there's stable hemoglobin trends. That's when you discharge your patient. Now coming to the third. Yeah. The third is your autonomic storm syndrome. Yeah. And that is usually caused by your widow spider, or you can go for your Indian red scorpion. Yeah. So in this cases, there is 2 syndromes that you can go for. Okay. That is the autonomic storm syndrome, and there is myotoxic toxidrome also. Hello?
Yes, yep. Yes. Yeah, you're on.
Yeah, right? Yeah, okay. Sorry. Yeah. So the autonomic storm syndrome, what happens here is there is a release of endogenous catecholamines. So that causes alpha and beta adrenergic overstimulation. So when your alphas and betas get overstimulated, what happens? There is diaphoresis, there is hypertension, everything is just shooting up. So there's cardiogenic shock, there's tachyarrhythmias, priapism, flash pneumonia. So it's always everywhere is high. So there's fluids, there's BP, there's everything goes up. So the primary suspect in that case will be a scorpion sting. Okay, usually we have the Indian red scorpion is actually the culprit, the most common culprit in India. And the next toxidrome is your myotoxic toxidrome. Okay, this is usually by your sea snakes or your certain land vipers. Okay, and in this case, what happens is there is systemic rhabdomyolysis and there is skeletal muscle breakdown. So what will the patients what will the patients present as? They'll present as severe muscle aches, dark color, cola colored urine, and they can actually have acute kidney injury. So in this, if the patients present in this scenario, the first thing that you can do is first line antidote, that is your prazosin. Prazosin can be administered. Okay, that is 0.25 mg to 0.5 mg for adults, and you should repeat it in 3 hours if needed. And next, you have to monitor, look for any tachyarrhythmias. As I've told, there is alpha and beta adrenergic surge. So in those cases, we have to always look for a 12-lead ECG and monitor for any AST changes, any low QRS voltages, or any tachyarrhythmias. Third is avoid heavy loop diuretics, because there is surges there, right? Adrenergic and beta alpha and beta adrenergic surge is there. So that itself causes pulmonary. As such, there is no fluid overload. So always treat the pulmonary by reducing the afterload, that is with prazosin. And usually scorpion bites and the widow spider bites are really painful. So always go for, aggressive analgesia. Yeah. And also, this pain can actually cause secondary sympathetic drives can actually be stimulated. So in those cases, when you give opioids or local nerve blocks, that itself can decrease your secondary sympathetic drives. Now, when do you discharge these patients? Normalization of heart rate, blood pressure should be normalized, and complete resolution of your hyperhidrosis. And your pulmonary crackles should be settled. Your ECG should show a normal rhythm for at least 12 hours, right? So this is your third syndromic approach. Next is your local necrotic protocol. That is your pit vipers and your reclusive spiders. So in this cases, what happens is when there's a bite, there is phospholipases, there is hydrouronidases that actually causes severe cell membrane disruption. And that can cause local ischemia, tissue necrosis. So there'll be only local reaction. Now, what they can present as is severe burning local pain, and you can see a rapid expanding edema. So always, when you get an unknown bite, please do mark the bite, okay, and circle it out so that you can also have an assessment whether the swelling is increasing. And also when you admit the patient, the admitting physician can also know that, okay, this was the swelling, now it has progressed. So always mark your bite marks when the patient arrives in the ER. Okay, and the next they can develop is ecchymosis. Blisters can happen, and that can secondary lead to necrotic sloughing. So in these cases, what happens is we have a trap here. That is your hump-nosed pit vipers. Okay, as you have known, the standard Indian polyvalent ASV does not cover up hump-nosed pit vipers. It does not provide any therapeutic cross coverage also. So in those cases, giving ASV is of not much use, but we actually tend to give also because to be on the safer side. Next is always have a wound tracking. That is, as I've said, always outline your marks and reevaluate, remeasure every 2 hours when you get this patient. How do you do a local management? Elevate the affected limb to your heart level and also give intensive wound care. That is, give adequate wash. Everything should be given for the wound. And obviously, if you see or if you suspect any compartment syndrome, always go for a surgical and orthopedic consultation. That is how do you know this compartment syndrome? There's a pain out of proportion, there is pulselessness, or if you see any deep necrosis, always have an orthopedic or a general surgery consultation. Now, when do you discharge the patient? Stabilization of all your necrotic borders. There should be clear early wound healing, and all the pain should be controlled with oral medications. That's when you discharge the patient, right? So this is actually the fourth syndromic approach to your patient when they arrive in the ER. Now, what are the bedside diagnostics? Okay, as I've told before, a whole blood 20-minute whole blood clotting time, okay, should be done. Okay, and that is considered the gold bedside standard. but we do have a limitation to it. So always try to catch blood in a dry new glass tube and place a 2 ml of the venous blood undisturbed for 20 minutes. And then you tilt to check. If there is no coagulation, then it is a positive test and you can go for ASV. But as I've told, there's a limitation. So you can actually, if there's not much signs, okay, and you're very suspicious, you can actually go for a PT, APT, INR, and then decide for an ASV. Okay, and next, what are the advanced laboratory testings that we can do? Is a complete blood count. That is, look for any thrombocytopenia, any hemolysis. You can go for a peripheral smear. Yeah, you can look for any hemolysis features. Next is you can go look for any signs of rhabdomyolysis, that is creatine kinase, myoglobins can be tested for. And always rhabdomyolysis lead into acute kidney injury. So always measure your renal function profile. That is the bedside or the emergent diagnostics or the biomarkers that are needed for an unknown bite. Now, how can we utilize our point of care, right? That is one, the weep sign. That is always you can look for any subcutaneous early fluid collections. You can actually track for those fluid collections or look for any interstitial edema. Okay, so that some, as I've told, that initially there won't be any local signs. So POCUS can be a tool that can help us to early identify for any local reaction. Next is always look for a vascular patency, because deep vein thrombosis, POAD, peripheral occlusive arterial disease, can also present similar to your bites. Except that, in some scenarios, we won't be able to see the bite mark, right? So in those cases, always just look for DVT, just look for any arterial, and look for any look for arterial Doppler, and confirm there is no issues in that. Next is cardiogenic shock assessment. That is, in scorpion bites, always what happens is there is toxin-induced myocarditis. So actually, they can cause, scorpion bites can cause LV dysfunction. They can cause global wall motion abnormalities. So always look for any signs of cardiogenic shock, right? So that is how you can utilize a point of care in unknown bites. Next is surgical mastery of local wound care. That is, a 15-minute rigorous washing of your wounds should be done. Okay, that is, soap and water should be used to clean your wound. At least you should do that for at least 15 minutes. If they're not done at home, please do it in your ER. Okay, and next is no touch closure. That is, always the mammalian unknown bites and mammalian bites, we actually don't do a primary closure. We leave the wound for delayed primary closure. Okay, and next is compartment syndrome. Always, because snake bites sometimes, right, they can actually rapidly progress into a compartment syndrome. So always look for pulse, look for any pain of out of proportion, and if there is any signs of compartment, always plan for a fasciotomy. And you should always give your ASV at the earliest and before starting ASV, we should actually go for premature incisions. Okay, I mean, we shouldn't go for any premature incisions that might cause that can worsen your bleeding, right? And next is immunoprophylaxis and antivenom stewardship. That is, as you all know, TT should be provided, and in case if your mammalian source cannot be ruled out, always go for rabies schedule as per Indian protocol. And also, in case of you're confirmed with a snake bite, always go for 10 vials of polyvalent ASV, right? And never administer ASV for asymptomatic bite. Always you have to look for your syndromic approach. And the asymptomatic bite protocol. So when any patients, as I've told in the initial slides, right, we actually have a symptomatic flowchart. We have an asymptomatic flowchart. So in asymptomatic flowchart, we should actually have the patients admitted. We need to admit the patients with unknown bite for at least 24 hours. Because I have told before, traits, they can actually delay, they can have delayed neurotoxicity, and it might take up to 12 hours to manifest clinically. So, and also in case of hemotoxic syndrome, any kind of intra-abdominal bleed, that can actually have delayed presentation. So they might develop pain in the later basis. And also, if in case of neurotoxic, we won't find any neurotoxic symptoms in the on arrival. So we'll have to observe them for at least 24 hours. Okay. And your whole blood clotting time, if it is prolonged, right? And also, if it is not prolonged, also we should have it done every 30 minutes for at least 3 hours, okay, during admission. And you should actually go for your neuro signs check. That is, look for pupils, you look for your neuro GCS, and also look for any local signs. So these things should be monitored while we admit the patient. So if the patient remains asymptomatic all throughout 24 hours, plus they have normal baseline labs, and the patient's completely stable, they can be discharged. But if any of the syndromic, if the patient falls into any of the syndromic metrics, definitely they need to be monitored again, and they will have to be administered targeted antidotes, right? So this is your asymptomatic bite observation protocol. Now next is the antimicrobial decision making. That is, in case of insect bites, if there's arthropods, prophylactic antibiotics are not strictly, they're not actually indicated. It can be avoided. Okay, but in case of mammalian puncture suspicion, you can actually go for oral antibiotics. That is your amoxicillin plus clavulanate. Clavulanate can be administered. And in case of some patients can present as delayed, that is, they can have secondary bacterial cellulitis. In those cases, you can go for flucloxacillin or clarithromycin. So that is how you go for your antimicrobial protocol. Yeah. So it was, and the core summary is that first, ABC, that is our core thing that we have to do. That is airway and anaphylaxis. You have to resuscitate your priorities, and always override your resuscitation overrides your diagnostic workups. And you should always think in toxidromes. That is, classify your patient into, see that if they fit into any of your syndromic matrix. That is your neurotoxic, hemotoxic, autonomic, or your local necrotic tracts. Third is always track your bedside test. That is 20-minute whole blood clotting time. That should be done every 30 minutes for at least 3 hours. Always have your single breath count assessed very keenly, because as I've told, anxious patients, initially they might not be able to count until 30. So serial single breath count test can actually give us an idea if the patient is going into a neurotoxic, they fit into a neurotoxic syndrome. And always do not send off the patient thinking that, okay, they're safe. No, we'll have to closely monitor all asymptomatic patients with unknown bite for at least 24 hours. And as I've said before, whole blood clotting time should be monitored, single blood count should be monitored, your local reactions should be monitored, all your labs, baseline labs should be in your, should come in your normal range. And that should be there for 24 hours. And then only you will be able to discharge the patient. Okay. Yeah. So this is actually a very short topic that I intended to take this because this is something that we find really difficult to write for exam, right? It's a bit tricky on how to write your exam. So this is more of your practical and your exam oriented session. And the specific bites will be taken in our later live sessions like snake bites and how to go for asphenol will be dealt in our later live stream sessions, right? So I hope, I think I've made it a bit crisp, I think, yeah, and a bit more easier to write for exams. Yeah, and so, yeah, thank you so much, everyone. And it's a very, very short session compared to everyone else. I hope if there is anything to be clarified, please let us know through our WhatsApp group, that is EM-PACT Toxicology. And yeah, thank you. Thank you, everyone.
Thank you, Dr. Jerin, for the session. It was a great, concise session that we had, and it's better to, if we can build your knowledge on this concise version, it's very good for everyone. So thank you for this, and let's meet with another session very soon. Thank you.